Let's begin now with our provider panel discussion. And I'm going to welcome our four guests, beginning with the art therapist, Meg Carleton, our music therapist, Lorrie Kubicek, Oncology Chaplain, Katrina Scott, feel like I should be on that side to lend a hand, and our oncology social worker, Emily Doerr. Now, of course, I introduced them by only name and title, and I'm going to give them an opportunity each to introduce herself and give us a job description. So we'll begin with you, Meg. Describe what you do and what prepared you for what you do.
Sure. Well, I'm a master's level clinician. I got my degree at Lesley University in expressive therapies. And within the expressive therapies, which includes art, dance, music, drama, I specialized in art. And then I also became a mental health counselor in the state of Massachusetts, so I'm a licensed mental health counselor. And that's how I became qualified after lots of clinical hours and internships and different jobs post-graduation. So I'm a board-certified art therapist, and my job description is, sometimes people look at me like I've got 10 heads, and they're like, art therapy? Like, what are you gonna, do you interpret artwork, or are you gonna tell me how I'm feeling just by what I draw, or are you gonna teach me how to draw something? So I really have to do a lot of explaining, and typically the first 10 minutes when I work with people is saying, I'm an art therapist. I bring creativity into your experience. I help you find creativity within your experience. We don't need to create anything that's going to hang in the Museum of Fine Arts. You don't have to be an artist. If you don't draw a straight line, that's great. If it's just stick figures, fabulous. I like to use the word creativity. So I like to find areas in people's lives where they're already creative. And then I like to meet with them and have a conversation with them and figure out how I can help support them in their journey here at the Cancer Center using creativity. So I'll meet with people inpatient, outpatient, and then we also do different groups. And I like to say that it's a very individualized experience. So really what I do is have a conversation with people, figure out together where they are and what could be helpful in that moment, and then we together find a creative process that can help support their needs.
And Lorrie, from art to music, I would imagine kind of a similar journey for you to what you do.
Yeah, I am also one of the expressive arts therapies. So my job as a music therapist, so music therapy is a clinical and evidence-based use of music to work on different goals within the relationship with a board-certified music therapist. And again, similar to Meg, the training is very rigorous, and you do a specialized accredited music therapy program. You have to complete a music therapy internship, and then you also have to sit for a board certification to become a music therapist. And my job is similar to Meg's in that people have preconceived notions about what they fear music therapy might be, and they're like, please don't make me sing, or again that same kind of gut reaction about, oh, what is music therapy? So again, a huge part of our job is actually explaining what music therapy can be for the individual that's sitting in front of us. Because for every single person, it's very different. You do not need to be musical to benefit from music therapy. You just have to have a connection to music, which almost every single human that I've met has a positive connection to music in some way or another. But my job as a music therapist is to pair my expertise as a clinician who studied music therapy with that individual's interests and those threads of possibility about how music connects to their lives. And then both of our jobs is to kind of connect them so that they can work on goals, or they can work on finding meaning, but through ways that they had no idea they could access, because I know how to use the qualities of music to create a successful music-based intervention that no one would ever believe that they could do. But that's what my job is. My job is to set the stage, if you will, for a potential music intervention to happen so that they can work on feeling less isolated, increasing their coping, feeling more relaxed, connecting to their kids that they have to be away from for weeks at a time. So it's my job to figure out how that might happen, but it's their job to be open to the possibility of trying something they didn't think they could do.
Katrina and Lorrie said that everyone has a connection to music. In our conversation the other day, you noted that everyone has a spiritual side.
Yeah. Hi, just for my credentialing, I'm board certified by the Association of Professional Chaplains, and in order to do that, you have to have a seminary degree, a 3-year or 2-year MDiv or MTS. You need 6 units of clinical pastoral education, which are 400 hours each. So that's 1,600 hours, and then you have to work for 2,000 hours before you can go in front of a board. So it's a counting education. It's a pretty long process. I also hold a specialty in palliative care as well, and that was above and beyond my other specialty. No one knows what a chaplain is. When I walk in a room and if I say, "Hi, my name's Katrina, I'm the chaplain on the floor," they're like, "What? Who? Am I that sick?" I call it the clergy fear factor. And but I use a broader definition of spirituality. Oh, sure. Is that better? Okay. I use a broader definition in my practice, in my clinical practice of spirituality, that I just want to share with you. There is a difference between religion and spirituality. I think religion is like, if you're looking at an umbrella, the framework that people go by, that is kind of organized with community, and then spirituality is kind of the bigger umbrella. And a lot of people now don't follow any particular religious structure. So I come at my role as a spiritual care provider, and in fact, we just changed our name from the chaplaincy department at Mass General to spiritual care, because it's more inclusive. So I'm going to read you a kind of the accepted definition of spirituality, and you'll see that it really covers everything. If you are an atheist or just don't have a belief in a personal God, you still have a spiritual side. Spirituality is the dynamic aspect of human life that relates to the way persons, individual and community, experience, express, and or seek meaning, purpose, and transcendence, and the way they connect to the moment, to self, to others, to nature, to the significant and or the sacred. Spirituality is expressed through beliefs, values, traditions, and practices. So in that respect, everybody has a spiritual side, and I have to say, I have not had cancer myself, but my husband, both my parents and my sister have, and for each of them, their cancer journey was also a spiritual one. It's about making meaning with the threat of a serious illness, and my job is to provide a safe space for people to reflect on that and where they're at, and whether their spirituality is in a good place or a bad place, and how we can maybe tend and mend their spirit.
And Emily.
Let me know if, I messed this up already. Let me know if you can hear me. So I am a clinical social worker. I have a master's degree in social work. During the graduate program, I did 2 years of clinical internships and then postgraduate work with supervision. My work at Mass General is in the breast clinic, so I am specialized just in breast oncology. And in that setting, I work with patients individually, I work with families, and also occasionally in groups, providing counseling. And the social work perspective really focuses on the person as the expert. So the person is the expert in their life, in their disease. And so our job as social workers is to work with patients to identify their goals, their wishes, and then really advocate for them with the greater team. So that could be in a family conflict, that could be in determining goals of care, but we're really there to provide them with support in, reaching their own goals. So that's our social work perspective.
You guys have expanded beyond just credentials, but you've laid out your credentials. What are the qualities, characteristics that you need to do your role and to aid your patients and help them discover meaning in their journeys? And we'll start with you, Lorrie.
I think for music therapy, for me, one of the things that I need to have is first that ability, and you're going to hear this many times, to establish a connection with someone, a safe space where they, again, can see the potential of whatever it is that you have to offer. First, you have to just connect with them as a person. But then I think to be a really good music therapist, especially in the adult world, it's a lot easier with kids to just help them get into music. But with adults, I have to be really thoughtful and creative about, again, taking those potential interests that I'm hearing, those potential connections that they have, and really tying it to a clinical music intervention that could possibly help them in one way or another. So number one, you have to be able to make a really authentic connection to someone, have to help them laugh or laugh myself, and then also be able to really figure out how can music actually help you during your journey.
How about you, Katrina?
My mantra, and I think one of the reasons why I'm pretty good at what I do, is I'm super curious. I can have a conversation with a person and hear about their life and am really mesmerized if they're a stay-at-home grandmom who's been raising kids or they're a Nobel Prize winner. It's the human condition and how our spirits are supported by connecting to something greater than ourselves, and what that looks like is fascinating to me. I like to say everybody has a belief system that they live by, and it's really, I think I have the best job because I hear about their belief systems. Another thing that's important in my work is non-judgmental listening. I would never ever tell someone their theology is bad, like, oh no, God doesn't work that way. Of course God works that way. God's big enough to do whatever God wants to do. And I also think that the ability to be empathetic and have empathy in listening to someone, to ask questions and not to give answers is kind of key. So for me, it's really curiosity about the person's life, the journey they've been on, and how things are working for them. I call it spiritual wellness is when external factors are coming at you, whether it's your chemotherapy or your radiation. Excuse me. And to be spiritually well is to have that inner self that can somehow handle and cope and negotiate those external forces that are hitting on you. And I think my role is to reflect with a person on ways that they can find for meaning making through times of suffering and change.
Emily, Meg, are there other characteristics that are essential?
Yeah. I think particularly in a medical setting, there's a big focus on fixing a problem. And so often a social work referral will be placed because, there's a concrete problem or someone is struggling with depression, or financial issues, and the social worker gets called in and to fix the problem. And typically I think what actually works best is just listening and bearing witness, and sitting with a patient and letting them tell their story. And there's something powerful about that provides some relief without actually fixing. A lot of these problems are not fixable, but listening and not trying to fix and just validating, supporting, is a big part of what can provide some relief and over time maybe come up with some solutions.
And I think it's coming up with the solutions together. Like everybody said, it's really patient as expert and really using those listening skills. I say that, or the way I think about it is that I translate things and I facilitate things. So I hear what people are saying to me, and when they're talking to me, I'm going through my head saying, oh, how can I translate that into some sort of creative process that can provide support in some way that will be meaningful to that person. And then it's my job to facilitate it. So those people who say, I'm not an artist, I don't, then I say, okay, yes, and this is how, or have you tried this? And so I'll say an art therapy joke because Lorrie had her music therapy, but I often think outside of the box, right? So the pun is intended, you know. There are lots of boxes in this world, and sometimes we get stuck in those ways of thinking. And if you can engage in thinking with a different part of your brain, trying something new that you surprise yourself, you never thought you'd ever do this before, but you're just, you know, you're willing to try something. Thinking outside of that box might help you look at whatever you're dealing with a new set of glasses, a new lens. And then I also think using curiosity, humor, playfulness. As adults, you know, sometimes adults don't really engage in play, and we're also serious all the time. So sometimes it's just saying, okay, let's not judge ourselves. You know, maybe your art teacher said that you were bad at art in 5th grade and then you never use markers ever again. But let's pretend she never said that, or let's just do this anyway and see what happens. And so just throwing the caution to the wind and saying, like, let's just try this out and see what happens, and just have an open mind.
Yeah, in hearing all of you discuss those qualities, characteristics, and you talk about making a connection and maybe the skepticism that you might meet initially if someone doesn't think he or she is an artist or a musician, or perhaps there's reticence from those who wonder, why is there a chaplain talking to me? And you've described some of the ways you establish a connection. Trust, in building trust. How important is it for you to establish the trust from the patient in you that you have his or her best interest at heart, but also that you're willing to let them guide you to wherever you're going to go in your respective therapies? And Emily, I guess I'll begin with you.
So I often see people when they're getting chemotherapy. Sometimes they don't know that they were referred to social work. So I show up, and it's challenging because they're in a really vulnerable position and they actually can't leave. And so I just show up and kind of feel like I'm imposing myself on them. And at first they may say, I don't need anything. I sort of explain what I do and my role is. Normalize that involving social work is a really normal, you know, it's a part of this. Prefer to have more people meet social work earlier on, to be honest, for all the reasons we discussed earlier today. But sometimes the first visit they say, no, I'm all set. And then I just keep showing up usually. So I'll see when they're coming in next and I show up. If they aren't scheduled for another month, I might call them at the midpoint. And people over time, sometimes, not always, reflect back, you know, after maybe 8 months or a year and say, you know, I realized that I could trust you because you just kept showing up. So I think making yourself available, you're going to be a presence and you're going to be there should a need arise, because there will be a need that will arise. So, you know, I think unless someone tells me, leave me alone, don't ever come back, I usually keep showing up.
Anything that you'd like to add, Meg, Lorrie? I guess we'll start with Meg.
I think so with art therapy, I'll meet with people sometimes for a one-time experience. Sometimes I'll see them 3 times. Sometimes I'll see people weekly for months. So it really depends. So I think we all have different skill sets and ways that we establish relationships. But I think the authentic listening and really showing that, you know, it is an honor to work with you, and let's see how we can work together to translate our experience together into something meaningful. And I think with the art therapy, I should mention that we can do this verbally or non-verbally. So typically you have a verbal interaction with someone just to set the scene and to get started. But then sometimes we use words as our mask, or we use words just to talk and keep people away or to talk over an issue. But when you use an image or an art process, it's a body experience, and the words don't really get in the way. And so the images start speaking for themselves, or you have this relationship and you develop this trust with these images that you didn't even know existed. And then we circle back and we bring the verbal communication back, and we sort of check in about what's going on. And I think that helps to solidify a relationship if there is any question in the beginning. after you've gone through the process and you've had the experience with the art materials and then with the provider, I think that's one way that you can help to solidify that.
Mm-hmm. Well, Lorrie.
One thing for me, I really like to provide them both the opportunity to say no to an intervention. Like, that's a very powerful tool to have. But at the same time, really balancing that with me doing everything in my power to help them say yes. It's a really fine line, because sometimes even just by giving them permission to say, you know, so here's an intervention that I think could maybe help you with some coping skills or help you relax. Why don't we just try it for 2 minutes? And then at the end of the 2 minutes, I'll ask you whether or not you want more, whether you're all set or you're all done. And so just, again, being really creative on my feet and helping kind of read their energy, and then providing ways that they can say yes as much as possible, even if that's just giving them a safe space to try it for just a little bit and then reassess what it is once they've taken the risk to kind of interact with whatever modality it is that we're bringing to them. So that's another thing that I will often do.
And Katrina, you drew the distinction between spirituality and religion or faith. How do you combine spirituality with each patient's faith or whatever they worship or don't worship?
Yeah, when I first of all, spiritual care is one of the few consultation services here that we don't need an actual referral for. So especially in the inpatient units, I rely on nurses who will say, you know, Katrina, this person's really struggling. Can you go in and see them? And I say, of course. And I also round quite a bit as well. I look to see how long the patient has been on any particular floor. Anyway, I introduced myself as a member of the clinical team, and that because most of the people here are looking at physical concerns, I follow a really holistic model of providing support for the patient's heart, mind, spirit. And so I align myself with the team that I work with, a multidisciplinary team, and so that they can see me in that way. And then the very first thing I usually ask is not what their beliefs are. I don't want to get into that. I want to ask them about their cancer journey. How were you diagnosed? You know, what has that meant to you? And then after I've kind of get a gist of who they are, where they're coming from, then I'll ask them if they have any spiritual or if they follow any spiritual or religious practices. If they say yes, then that takes me one way. You know, tell me about your religious or your faith tradition. Is it a meditation practice? Is it going to church on Sundays? What is it? If they say absolutely not, then I use another tact, which is asking them about where they find strength through difficult times. Is it family? Is it their inner selves? Is it their pets? Whatever, but however they find strength and hope. And that's just starting a conversation, and it really is what all of us do here. We basically listen to the voice of the customer. We're getting all of our information from that patient. I never look at a chart note before meeting a person, because I want to hear their truth, their story. That's most important to me. And I know I've said this to a bunch of people, but I kind of consider myself a sponge. You know, I hear their story, and I'm able to reflect back and to pull different threads from what they've told me to see, is God working for them now? Are you angry at God? Is God helpful? You know, how's your family? Whatever, however they find support and meaning, anything that's holy or sacred to them.
We want to hear from your voices. I won't call you customers, but we'll hear from your voices momentarily. I do have a question, and Emily, you said when you meet with the patients, they are about as far removed from their environments as they could be. And you have all said in our past conversation about the importance of, talked about the importance of dealing with them in their own environments, your patients in his or her own environment. What does that mean? How do you do it? And I guess I'll start with you, Katrina or Lorrie, if you feel free to go.
Oh, sure. When I go into a patient's room, the very first thing I do is look around to see if there are any icons or any type of flowers, if they can have flowers, what they're wearing. And then also just trying to bring a sense of my interest in what their home life is, and who they are at the top of their game, not the person who's just had 5 rounds of chemo and is really sick in bed. And I think that's environment. It's remembered wellness. It's about having a calm presence with people and an accepting presence, and to never, ever shy away from anger or frustration. And as Lorrie said, they can say no to me, and I am absolutely on top of that, because that's giving somebody back a sense of control, maybe in the face of no control. But for me, their environment and where they're at is probably most important. A clue is if somebody's wearing rosary beads around their neck. That's definitely a clue to me.
I have 3 questions that I love to ask almost everyone that I meet. First question is, have you ever touched an instrument? Even dabbled or seriously trained? Like, what have you tried even once before? The second question, which is my favorite, is if you could wake up tomorrow and you were magically amazing at any instrument you never had to practice, what would it be? And of course, voice is an instrument. And the third question is, you're stranded on a deserted island and you can only bring 1 CD. What CD do you bring? And for me, this is the ultimate glimpse into both the environment of what music has been for them and what they've always dreamed of what music might be for them. And again, those are those threads that I'm gonna pull on to see if I can come up with some options for interventions, like creating a playlist, or trying a harp for the first time, or writing a song, recording a song, producing a song, whatever that might be for them that's going to help them make meaning to the best of their ability.
And you,
And
Meg?
for me, I think about the physical environment and then also the emotional environment. So I think a lot of us have carryovers with our disciplines, but I'll walk in a room, an inpatient room, and I'll look at the photos. You know, is there a piece of art on the wall? Did someone hand make something? Is it hanging up? Is it somewhere? Do they have a shawl on? Are there bracelets? What colors are in the room? So I try to find something that can identify people as an individual within this hospital system. And I also work with people to alter their physical environment so they feel more comfortable here. So maybe they can't stand the artwork that's on the wall in their room and it's making them feel dizzy because it just wasn't the best choice. So we might make a collage using images that they find soothing or inspiring, or maybe pictures of their family members or their friends or their pets. And so we can alter the environment by creating it physically in the space and hanging it up. And then I also like to think about the emotional environment. And I think, Katrina, you said remembered wellness. Is that so? So the emotional environment, like these people that we're working with are not necessarily where they want to be. So who are they when they're where they want to be? And so I like to think about concepts like the clinical concepts, like attachment. Like, who are you connected to? How do you, who or what or where helps you feel secure? Where do you find your source of strength or your energy or your inspiration? So I like to think about those connections, and I like to think about wellness too, thinking about practices of self-care. How can you create an environment within your own being here when you're removed from where you want to be to help you feel more grounded, more secure, more stable, more supported, and more cared for? Yeah. And connected. Connection's a huge thing. So how do you still feel connected even when you're not where you want to be, right, or you're not with the people you want to be?
And I would just add, I only see people outpatient typically. So when they're getting chemotherapy, there really isn't a lot of personal stuff around. It's pretty impersonal. Their goal is to get out of there as soon as they can. But the way to kind of bring in their outside environment for me is, often patients, they feel like they're defined by this patient role. That's the role they're playing right now. So what I try to do with people is ask them about the other roles in their lives, because those are just as important, more important actually, but they sometimes get lower and lower on the identifier list. So what is your role at home? Are you a mother? I work in breast cancer, so it's typically women, but a mother, are you caring for elderly parents? Are you you're a sibling? Are you an employee? All these different roles in your life, and finding out more about the system that they live in, and really trying to emphasize those roles above the patient role, and thinking about, while you're a patient, you also are doing all these other things, and how do we help you cope with that patient part of your life so that the rest of your life has meaning?
I'm an art therapist and a licensed mental health counselor, and I am so thrilled to hear each of you speak and hear and know of the support that you have been offering, because it is so crucial. It is so crucial. What you do, it goes hand in hand with what the doctors and nurses do. And thank you. Thank you. Keep up the really good work.
And I can respond to that. I think it's really important that you brought up how it goes hand in hand, because we're in a medical institution that is dealing with disease and medical treatments. And it's really, it's a fast-paced environment with a lot going on. And so sometimes, you might get a pamphlet with a folder in it that tells you about these workshops, but you're so focused on this medical diagnosis and all the information you're trying to keep in your head that oftentimes, how do you get these services gets lost. So it's so important to hear from people, and so we can reiterate that. But then also about how you get the services, but also about the collaboration that we have with the cancer treatment medical team, and then the psychosocial services and the chaplaincy and the integrative therapy services, that we all work together because we really view the whole person. We're treating the whole person, and that's mind and that's body. And having these different modalities can meet different needs for all the various people that we provide services for. So it is a team effort, and it is, maybe someone's about to go into surgery, and so we learn a little bit about what's going on with that. We can connect with their medical team so we can provide better support with our own modalities. So it is that connection. So thanks for pointing that out.
Go to this side of the room. Oh, next.
You talked about a lot about the services that you give, and for me, it appears that it's everybody in-house. What happens to the patient who gets referred? They have their surgery outside, and then they come here not for chemo, but for radiation, because I went through radiation for 6 weeks. I never heard about any of these services. And then when I did want a support group, I had to search and find, and basically had to develop a group. And because of the doctor that I had met, I was able to get involved with PFAC. So that's a concerning for me, because if I came here like that, how many other people are coming here like that that don't know these services? And even though my situation might be different, it's the same, because just because I didn't get that terrible drug, I still had to go through radiation, and that last week of radiation is really powerful, and it really makes you really believe and know that you have cancer. And what am I going to do after this radiation,
So I just want to say, I actually meet with a lot of people in exactly your situation who had surgery and then radiation and didn't, I couldn't capture them in chemo. And sometimes I don't hear about them until their 6-week post-radiation visit, and they're having a hard time. And I often wish I had known them prior, especially when you're coming in every day. I would love to have met you. We do have a social worker in radiation, but all of us are happy to also meet with everybody in their specific disease center. We do still see people when they're doing radiation and as they transition out of treatment, because that's actually a really difficult time. But again, yes, I think we just need to do a better job of letting people know we exist and how to find us, because we are here for that as well.
We'll get to two more questions, one over here, and then we'll come back to you. Go ahead.
This question is addressed to Lorrie. Is there room in your practice for a volunteer to assist you?
That's a great question. So we don't have volunteer music therapists because you have to be a board certified music therapist to actually practice. But we do have an environmental music program where we bring in musicians. They go through an audition process and a vetting process through volunteer services, and they can provide music in the public spaces of the hospital. So that's a program that I also manage, and I've got very high standards, but I really care about making sure that the music experience is a really positive experience. So that is the only way that a musician can come into the hospital is through the environmental music program. That's a great question.
And go ahead.
First off, thank you all for what you do. What I'm hearing, we have therapy that while we're currently in treatment, and one of the things that I wanted to have each of you try to address was legacy creation. I'm a stage 4 cancer patient, so one of the things that I often struggle with is how can I make sense of what's going on with me? How can I make a difference? And how can I make sure that I get the message, what I'm leaving behind, a message that I want to get to my children, to my family, to my friends, whether that be an original music composition or a piece of art or a blog or a story that I want to leave for my family. Can you each address how you could help us to do that?
Sure. I actually received training in a therapy called dignity therapy, which is called that because it was started in Canada, and it's a legacy document. And in Canada, if something's labeled a therapy, nationalized medicine pays for it. Here, they do not. So I went for a grant with the Cancer Center for transcription services to pay for the transcription of an interview that I do with folks. And I've done about 50 or 60 of them so far. It's a structured interview. You get the questions. There are 9 questions that you get at least a couple days before that you have a chance to reflect upon. But it mainly is your life story and also all the hopes and dreams and wishes you want for your loved ones. The interview takes about 50 minutes to an hour. It's sent out for transcription. I get it back. I edit it into a narrative, which is easy for me because I was a filmmaker for 25 years, so I'm kind of used to putting stories together. And then the person and I review it together. I read it out loud. They make any changes or additions, which everybody always does. Like, I never should have said that about my sister. And then I make those changes, and then I email the document as well as give the person 2 copies of the document, and it's yours to do with whatever you want. You could put it in a sock drawer. I've had patients give the information to their clinical team because they wanted people to know who they were, where they came from. So it's all over the map. So we offer that service, and there are handouts in Yawkey, and also I've done trainings with all of the infusion nurses as well as the inpatient nurses to identify people that might be willing to do that. But I have to be honest with you, when I give them the questions and then I come back to talk with them, at least 50% of the people will say to me, I'm not ready for this yet, because it talks about your hopes and, yeah. And Megan has, yeah, she's awesome.
Yeah, so Katrina and I do a lot of work together, and I think this is, it connects to what Dr. Ryan was speaking about with the prognostic awareness and how some percentage of people like to know what's going on and the numbers, and they need that information. And then there's another percentage of people who might not want those details and come from a different vantage point. And I think that's where our services can be helpful, because in working with legacy, some people want to address it directly, and some people, there's something in them that wants to address it, but if you say those words, that's not happening. And so our different modalities can help support people in different ways. So with the art therapy, I can talk to someone and sort of get a gist of what they're saying, and then without even saying the word legacy, I can say, why don't we, depending on, the situation, but sometimes what I do is I'll work with everyday technology that's accessible to people. Most people have a phone, most people take photos, most people have seen videos, so I'll work with people and say, you wanna make a video? Do you wanna record a message? Do you wanna read a bedtime story? And I'll film you, and then we'll take photos from your collection, we'll put it together, make an iMovie, and then here's a DVD for you to have for your family. And so I guess we just call it the video project. So I'll work with people and do a video project based on their interests. Maybe someone's having a birthday and they have visitors, and I'll come and take some photos and videos, and then we'll put it together and then in a session, and then they'll add some of their own personal photos. And so we have that document that that helps people feel like they're making a difference, because you made an actual product and you can enjoy it together, and you can also give it to somebody else. And then there are also other ways, like oftentimes I'll use oven-baked clay called Sculpey, and it's really simple. You just need 10 minutes and a thumb or something, some sort of, so I'll make a ball of Sculpey and you'll press it down, and then I say, you want to make a thumbprint, and people can create like a worry stone or a physical, tangible object that helps people feel connected or grounded. So you're rubbing your thumbprint on the thumbprint impression that was made in the clay. And so you can make like 20 thumbprints really easily, and people often find that they like to make keychains out of them, give them as gifts to people. I said I like using boxes, so sometimes we'll decorate boxes and people can gift boxes that they created to other people, put special things to hold them. So lots of different ways, and we can speak about it directly. We can talk about, where are you going to use this video? Who do you think you're going to give it to anybody? We can, and sometimes just starting with the creative process as the door opener, then we can get to talking about the intentions, whether it's legacy or attachment or whatever. And sometimes we have a little bit more success in that area with some people, rather than saying, hi, I'm Meg, I do legacy work. And then people say, oh, see you. I have an appointment. I'm about to have a visit.
And I just wanted to add something real quick. I think kind of building on that as well with music, obviously writing a song and recording a song, producing a song is something that you can do anytime. It doesn't have to be legacy work. So as a part of my practice, I try to record things all along the way, because it's such a beautiful, tangible representation of a really positive experience you've had at the hospital. Someone you're going to meet in just a little bit, Kimberly Kerr, is over there. She's a music therapist with a program in the community called Next Step that specializes in work with young adults with medical needs, and she has her own recording studio. I have a little laptop at the hospital, but so I will refer patients who really want to take the songwriting process to that next step, again, if you will, because that's their program's name, and I will send them over to there if they fit within that young adult population, to just get their story out there. And then if it does come to pass that they need that legacy work, you've already begun the process of it, and then you can start looking at it in all different ways, or record a second piece, etc.
Great. Meg, Lorrie, Katrina, Emily, thank you guys so much.